Yeah.
All right.
Thank you.
Thank you. So there are several areas of controversy and real-time clinical questions which may come in iBanking and dealing with real-life situations. For many, we have policy, procedures, and guidelines into place because of the cornea donor study, which are benchmark studies. But for some, we have to go back to our basic medical knowledge and observations of clinical practice to apply them in iBanking. Now, when we say good quality pays rich dividends, this is most applicable to keratoplasty because a good quality donor cornea is paramount to achieve the desirable outcome after keratoplasty. In terms of safe corneal practices for donor corneal retrieval, it is the evidence says that when we use povidone iodine 2.5% for 5 minutes, this is best measure to prevent the post-keratoplasty infections. And one should also avoid the donors which are at high risk for subclinical infiltrates and contaminations, mainly the ones which come from ventilators of more than 72 hours and confirmed sepsis. Donors' medical history is very relevant. We have to rule out medical contraindication, which could be infections. Serology tests are very important for ruling out HIV, HBsAg, HBC, and syphilis. However, for COVID-19, it was never a mandate. Malignancies, in terms of systemic malignancies, lymphomas, and leukemias are absolute contraindication, and so are the intraocular malignancies. Certain systemic diseases affect the corneal donor endothelium, which are chronic kidney disease patients, donors, and the diabetic mellitus, which are uncontrolled because of severe other reasons, several reasons. So these have to be looked into account when we are planning for transplant with these corneas and cornea donors. Donor cornea evaluation involves the salient parameters which is important is corneal endothelium, stromal characteristics to rule out scars and arcus, epithelial status, corneal folds, stress lines, scleroderm. All these are important in the present times of lamellar keratoplasty. The criteria for suitability of an ideal donor parameter will vary with the type of keratoplasty, and with the popularity of lamellar and component surgeries has expanded the utilization of the donor pool, and tissues with poor endothelial health and older age could also be utilized now. When we talk about the anterior lamellar keratoplasty, one should look at the tissue does not have a significant arcus. There is no stromal pathology because many of these cases will be requiring a graft, larger grafts also. And for keratoconus, it is also important to select a donor which is slightly older, more than 25 years, because there's no way we can rule out keratoconus in the donor. Anterior lamellar keratoplasty for just when we are planning for dystrophies, which are something like TGF beta induced dystrophies, which are based upon the abnormality of the keratoepithelium gene. It is important to select the donor corneas with intact epithelium because these will give a chance for better epithelial survival and later recurrences in these dystrophies. Donor epithelium is also important for indications where the limbal epithelial health is poor and for large grafts to preserve the limbal region at the time of keratoplasty. Now, with PK and EK, we know that endothelial parameters are the most important ones. And this slide shows the longevity of the graft. These were the PK grafts done 30 plus years ago, and we have the specular imaging counterpart to the clear cornea. Now, what determines the long-term survival? Now, there are various studies which talk about the graft survival in PK. So there are several studies which quote the long-term survival being 5 years is 69%, 62%, to best as 90%. Now, there are several factors which influence the long-term graft survival. The most important in best case scenarios is the endothelial health of the donor at the time of transplantation, which determines the longevity. Now, let's look at what is the normal rate of cell decline. Now, in a normal person, the rate of cell decline, endothelial cell decline is 0.6% yearly. Now, but when we look at the PK data, this is from the long-term PK data studies. PK data long-term shows that between 3 to 5 years, there's a cell loss of 7.8%. Between 5 to 10 years, it's 4.2%. Beyond 10 years, it is 1.8%, meaning that how do we interpret this data? So when we look at the post-PK endothelial cell loss, it is 13 times more in the first 5 years, it's 7 times more in the next 5 years, and 3 times more after 10 years, which is never what we see in the normal, which means that there's an accelerated endothelial cell loss in post-transplant patients. So what is the bare minimum arbitrary ECD to factor this endothelial cell loss, the accelerated cell loss which happens in PK grafts? So this data comes from Armitage, where we see that in the prediction model, so there are two exponential components. One is the rapid phase of cell loss, and second is the slow aging phase where the cell decline happens. Now, with this prediction model, we see that more than when you have a cell count of more than 2,000 cells per millimeter square, these corneas, these PK corneas, will have the potential to last for 30 long years, which is the best case scenario. Of course, graft don't survive that long, but then with the count of more than 2,000, there is a potential for the graft to survive for 30 long years. So that is why for the PK data, we take the arbitrary minimum as ECD more than 2,000 with the phakic donors. Now, what about the other transplants, DSEC and DMEC? Now, when we look at the endothelial cell loss pattern in PK, DSEC, and DMEC, the 5-year cell loss and the 10-year cell loss is sort of comparable across the various types of keratoplasties, which means that when we talk about the arbitrary minimum for the DSEC and DMEC, now because there are more steps in graft preparation, staining is needed, manipulation is required, we may extrapolate from the PK data. We have to factor that also into account, and that is why the bare minimum ECD for DSEC may be around 2,300, and for DMEC, considering staining and all, will be around 2,500. Now, when we talk about the assessment of endothelium, ECD is one parameter, but ECD is only the morphological assessment of the corneal endothelium. The limitation is that there's no way of having a functional assessment, and which is not a practical approach in the eye banking. So what do? There are other parameters which also affect the corneal endothelium. We need to be reminded of these parameters. And what are these? Most of these are related to the death to excision times. Now, in hypothermic preservation, the death to excision times is same as the death to preservation time, overall preservation times, and the impact of age. So there are variable studies which talk about the effect of D to P times on the corneal endothelium. Some studies have quoted that the larger and longer D to P times of more than 14 hours were not associated with any clinically meaningful reduction in donor ECD, infection, and primary graft failure. Similarly, there were many more studies to support this. Now, let's look at the cornea donor studies, which are the benchmark studies in keratoplasty. So D2P times in the cornea donor study with refrigeration were less than 12 hours. Without refrigeration were 8 hours. For the CPTS study, it was less than 20 hours, and without refrigeration was 10 hours. Now, the third source is from the European eye banks, where they take up to corneas which are 24 to 72 hours with refrigeration, and without refrigeration is less than 12 to 24 hours. There's a variability in the practice patterns. Our practice patterns are taking into refrigeration to account is less than 24 hours when the body is refrigerated up to 6 hours. And without that is less than 9 hours. This is based upon the study which we implemented at our eye bank. Now, what is about the overall preservation times? Now, with different preservation solutions support donor corneal and endothelial health to variable periods. Now, within the cornea preservation solution also, there's an endothelial viability which reduces gradually with preservation, and this is a time-dependent deterioration. So what is the effect of overall preservation times of endothelium? With respect to the CPTS study, the data says that there's no effect in graft success with the preservation times up to 11 days. But when we look at the endothelial cell loss 3 years, which was greater with the longer preservation times, but this is like with the 0 to 7 days was 37%, and 40% which with 8 to 14 days, which is sort of acceptable. What is the effect of preservation times and the post-keratoplasty infections? The studies from the US say that there's a correlation of post-keratoplasty fungal infection with longer preservation times. Now, in our setup, we use more of MK medium, which is a short-term preservation medium. So we have seen that the risk of fungal infections is low simply because of the reason that the tissues get utilized beyond the time period of 3 to 4 days, and which is the reason why we don't see so much of fungal infections compared to the US practice patterns. What about using the aged donors? Now, DMEC has generated a lot of interest in the older donors, and we can use these corneas, and this data has come from Dr. Basak, as long as the endothelial health is good, and this is what we were also practicing. Now, this is just to substantiate this evidence. This is a patient who had a therapeutic keratoplasty with an 86-year-old phakic donor, which had a good transplant, and this patient till date is doing quite well. Now, impact of age and graft survival in terms of the evidence from the cornea donor study, we see that at the 5-year survival, graft survival was 86% with the donor's age between 12 to 65 years and was similar between 66 to 75 years. The 10 to 12 years survival was also sort of comparable, but the age effect was seen at the extremes of the age group. There was a 96% survival for between 12 to 33 years and 62% survival for the donor corneas between 72 to 75 years. So how do we apply these evidences? So one of the important things is that when we do a transplant, we have to do matching of the donor parameters with the recipients in terms of age, indication, and the type of surgery. We should consider the age of the recipient and consider the age, the graft lifespan to the life expectancy of the recipients, meaning that we may not be very choosy about older recipients, but we have to be little particular about the patients in the pediatric age group where these evidences can be applied to the selecting the donor parameters. Now, with respect to DSEC and DMEC, there are a few criteria which are important. Now, there are two methods of donor preparation. Some of us do the manual dissection, and the eye banks do the automated method. The success of graft preparation requires a good size and regular scleral rim, and that is why when we are harvesting the donor cornea, it is important to have a good scleral rim in the donor corneas. The donor tissue parameters which are selected, as we discussed earlier, was more than 2,300. Ideal would be 2,500, but that is also okay. And age group should be about 10 years. Though there's no upper age limit, some of the sources recommend less than 75 years simply because of the differences in the practice patterns. Now, less than 10 years donor corneas may have a good outcome, and we may do these corneas use these corneas also for lamellar dissection, but dissection can be somewhat a little challenging with these donor corneas because of the inherent elasticity of the tissues. Microkeratome versus manual dissection, there's not much of difference in terms of visual acuity recovery, but in terms of the quickness of the recovery, there may be certain differences because the microkeratome tends to give a little smoother cut, and there is an advantage of having a greater consistency and more accurate donor thickness measurements with the automated dissection. The nomogram is followed at the eye bank to have a somewhat very regular kind of cuts, and ideal for use is 90 to 120 microns because of the ease of handling of the posterior lenticule. Now, when we looked at when the eye bank is involved in doing the pre-cut, what is the what is the variability? So majority of the lenticules which were prepared were in the range between 101 to 150, which is acceptable. And there was a good correlation between the pre-cut and the post-cut ECD when we did the study in over 1,000 plus donors. So it is important to look at the parameters. One of the important things is the graft thickness and the graft dimensions to plan out the surgery. And if at all marking is required in extremely thin corneas, one can do that at the time of surgery. With respect to DMEC, we know that the DM characteristics are very much related to the age of the donor. There are changes in the Descemet's membrane which occur with age. Younger donors tend to be thin and DM stripping can be difficult, and these are also elastic. So surgical manipulation during the surgery can be difficult. Older donors, on the contrary, can be brittle, they can be less elastic, and sometimes may not even form a scroll. So sometimes it becomes important to mark the older donors. Older donors, the donor age ideal for DMEC would be 40 years and above. Ideal would be between 50 to 70 years with respect to the nature of the surgery. Now, when we do a DMEC donor preparation, the corneas with Descemet's membrane properties that are difficult to peel usually come in mated pairs. So if you're finding a difficulty in stripping one pair, it is important to rule out the other cornea also for the DMEC preparation, because this tissue may also give a trouble because of the dense adhesion. So this is important factor to look at when we are planning for paired cornea for DMEC. Corneasol versus MK preservation. Cornea is compactor in corneasol, and corneasol is also somewhat little sticky in what we observe. So it is important to risk the donor cornea in corneasol before preparing for the DMEC tissue scroll, and it also helps to warm the tissue before donor preparation to let the tissue be a little swollen at the time of tissue preparation. Now, since we are also providing pre-prepared DMEC from our eye bank, now there are several questions which come up about whether we should give a complete scroll prepared or whether it should be just good enough to have a pre-stripped tissue. Now, what is the ideal? This is one question which we will face from the corneal surgeons. And the other second question would be, what is the ideal prep to utilization times and the ease of use? And what are the outcomes of eye bank prepared tissues? Now, with respect to what is the endothelial cell viability of the eye bank process, DSEC and DMEC grafts, for DSEC, the evidence says it's around 7 days, though we may not go up to that time, but this is the largest duration up to which when we have a DSEC tissue can be used up to 7 days. For DMEC, the evidence is for 4 days time. What are the effects of transportation? Although we say that there's no effect on the endothelial cell loss with respect to the duration up to 7 days, but sometimes the practical situation can be the anterior lamellar cap can be dislodged and the centration marks tend to become fainter with time. So in conclusion, keratoplasty outcomes are dependent on the donor parameters, and continuous research and investigations into eye banking practices will impact and enhance the success of keratoplasty in varied clinical situations. Thank you for your patient hearing.
Excellent overview and practical points, very relevant for corneal surgery.